Thank you for choosing Axxess On Demand. Axxess believes in continuing education, and we create content to empower you to learn and grow anytime, anywhere. Let's get started.
Good afternoon, and thank you for joining us for today's Hospice News webinar. Today, we're discussing a hospice quality reporting update, a path to compliance and success, sponsored by Axxess. My name is Jim Parker. I'm editor of Hospice News, and it's my pleasure to introduce today's speakers. Nanette Mitten, Senior Clinical Coding Manager for Mac Legacy, and Zondra Ellis, Director of Hospice Solutions for Axxess. A registered nurse who has served in a leadership capacity for more than 20 years, Nanette has held a variety of roles in the home care and hospice industry, including clinical, administrative, consulting, education, and agency startup and development. Nanette provides day-to-day coding and quality support to home care and hospice agencies. She also serves as a consultant for quality and regulatory issues that arise due to the complex and integrated nature of coding. Nanette's experience in the industry gives her a unique perspective and allows her to provide coding and audit knowledge firsthand to clients. Zondra Ellis oversees development of Axxess's hospice software solution, leveraging her many years of experience in the hospice industry to create a software that is easy to use and allows clients to be clinically, administratively, and financially compliant. Prior to joining Axxess in October 2017, Zondra served as the executive director for Kindred Hospice and Heart to Heart Hospice agencies across Texas. In this role, she oversaw a hospice house, created and implemented a company-wide QAPI program for an organization that served more than 2,500 patients, and used her experience to create operations that improved compliance and maximized reimbursements. Zondra's QAPI program helped agencies of every size improve outcomes for patients, stay compliant, and grow their business. Nanette and Zondra, thank you both for being here.
Thank you, Jim. I'm delighted to be here. Nanette, can you hear me?
I can. I'm delighted as well. I think it's going to be great information today for our attendees.
It's going to be awesome. So
excellent.
Nanette is driving today.
Before we start, I just want to a few housekeeping items. Just that phone lines have been muted for sound quality, and today's webinar is being recorded and will be sent via email afterwards along with the slides. I'll now turn the program over to Nanette and Zondra.
Well, Jim, I apologize for being excited and speaking over you, but I am delighted to be here. Nanette, my friend and colleague, is going to be driving today, so I'm going to ask her to go ahead and advance to the first slide. So today we're going to talk about the elements of the Hospice Quality Reporting Program. Some of you guys probably refer to it as HQRP. We're going to apply the current regulatory requirements of the HQRP in the daily operations of organizations. So we're going to talk about not only the regulations, but how they affect your organization and some steps that you can take to put them into action. Then we're going to talk about the Hospice Care Index, which I'm sure many of you already know about, but there are some details there. We need to dive in and take action quickly as it comes into effect in just a few weeks. And then we're going to talk about the future expansion of HQRP. All right, Nanette. So the agenda is putting hospice quality reporting into perspective, reviewing the quality reporting requirements, learn the Hospice Care Index, so not learn about it, but learn it, and explore those future changes that I talked about earlier. So I love to talk about quality. It's one of my favorite things. And I think the most important thing to do when you're talking about quality is to really put it into perspective, right? So it's not just about regulatory compliance and quality reporting, because it is true that you can have one without the other, right? So regulatory is in one bucket and quality, HQRP, is in another bucket. So you can't have one without the other, but when you combine the two, you ultimately have the provision of the highest quality of care for the patients their loved ones. And I will also add here, with the pandemic continuing to have a stronghold, that a strong regulatory and compliance, regulatory and quality program will allow your caregivers to appreciate the provision of that high quality of care. So you're also able to affect your turnover and possibly attract qualified staff. So by design, the HQRP is established by the Social Security Act, and a lot of people don't realize that, but it's really true. So it's a pay for performance. So what we know now is that if we don't report our quality data via CAHPS or HIS, we're going to get a reduction in payment. So that payment reduction is going to double in a couple of years. So now's the time, right, that we need to be paying attention. So promoting delivery of that patient-centered high-quality care that we talked about earlier, that's one of the things that is really important when we think about the why. So we want to, I like to think it's a competitive thing, right? So, and, you know, we're going to talk about the hospice index in a few minutes, but, you know, as it relates to HIS reporting and CAHPS reporting, I always want the best scores, right? So if I'm in a large organization, I want to be number one, right? If the threshold for your HIS data transmission is 90, I want to be 100%. So through those measurements, right, it really promotes the delivery of patient-centered care by hopefully bringing out that competitive spirit amongst everyone involved. So the way HQRP gathers the data is the organization's data, right? So CAHPS and HIS, and then claims-based data. So the level of care that you're providing. So we want to make sure that we understand the foundational goals. So the goal was to develop a patient assessment instrument, right? So, and develop the quality of care measures in accordance with assessment to make sure that we have strong, that we have a strong foundation of quality. So we really want to remember that we're evaluating our response as hospice providers to the patient, family, and caregiver needs, and also those quality measures that we talked about earlier. So we don't want to go too far away from that. So currently, the current initiatives are the Hospice Item Set, which we call HIS, and then the Hospice Care Index, which is new, and then CAHPS. That's kind of our recipe or equation for HQRP as a whole. Okay, so let's talk about the Hospice Item Set. So the Hospice Item Set should be familiar to everyone, but I really kind of wanted to present it here to bring it to the forefront. And as a reminder of, this is the data that we're transmitting, right? This is the data that we're collecting on admission and discharge, and we're sending that off to CMS. Patients treated with an opioid who are given a bowel regimen, I put that at the top. That is a quality measure, you know, but it's also a standard of care, right? We want to make sure that we have opioids, that those patients have a bowel regimen to go with it. Your patient screening and assessment, and you see dyspnea screening and assessment here as well. You know, it's not just, did we ask the question? If we got a yes, I'm short of breath, or yes, I'm in pain, what did we do to further assess that and or treat it? Treatment preferences are very important right now. There's lots of buzz around advanced care planning, which in hospice, we've been doing that for a long time. So not only are we looking at, you know, the DNR, right? We're also looking at how do they feel about hospitalizations and antibiotics. So it's a much bigger, it's much more than, do you have an out of hospital DNR question? Their beliefs and values are important. So really also part of that advanced care planning, getting to know your patient and what's important to them. Visits when death is imminent, and the hospice and palliative care composite measure. So a combination of all of the data points combined. All right, Nanette, let's talk about CAHPS. Everybody loves CAHPS. I think CAHPS is a very powerful tool for hospice organizations, and understanding that the data that you receive is collected after the patient dies is really important, because you got to act quickly. So when you get your CAHPS data, you got to swing into action there, right? So we want to make sure that we're getting good scores here. And when I look at CAHPS, a lot of times what I see is the communication with the family, training the family to care for the patient, and also getting timely help. So those three things kind of rise to the top of the areas where we need to improve. And I believe that hospice organizations are providing that support, but perhaps it's the way we communicate it. So when we're providing that training, that we're calling it training, right? That we're really having frank conversations on admission that says, we're available 24/7, and paint a picture so they understand that you're not going to be there in 15 minutes. I mean, you might be, but or more than likely, if they're calling after hours or even during the day, that you're going to have to, rearrange your schedule and take a little time to get there. So I think those things are things that to think about and things to communicate to ensure that you have the highest CAHPS scores possible. All right, Nanette. I'm kind of flying through here. We've got a lot of information to cover. So questions you may have. So what are the benefits of QAPI? And how do we ensure these requirements and goals translate into a quality program? Well, the benefits of quality assessment and performance improvement really give you a foundation when the first time you look at it. If you're new to a hospice organization, you're going to want to look at their QAPI information, right? So not only their CAHPS and their HIS data, but you're probably going to look at their PEPR scores. You also want to really understand what their QAPI program is. The QAPI program should be the hub of the hospice organization. So because quality touches everything from, your team members to your patients, your referral sources. So quality really lives in, and I like to say it should be a team member, right? So how do you get quality to be a team member? So you really have to walk the talk, and you really have to be talking quality every day. And what you will see with a good QAPI program is your organization will flourish, even in times of staffing difficulties or maybe, drops in referrals from hospitals. With a strong quality program, you have the ability to tell a story of that you're not just providing hospice services, but tell the story of how quality is infused in everything that you do. So how do we ensure that the requirements and goals translate into a hospice quality program? I'm pretty hardcore about this. I think it's important that you have a QAPI meeting once a month, right? And then you have a monthly schedule and a quarterly schedule and an annual schedule where you go in and list out the things that you're going to do as a leader to ensure that, the requirements and the goals that you have for your organization fall into line, and it becomes part of everyday life in your organization. So we're going to hop into regulatory overview here. And I know that sometimes we stop in sections and ask for questions, but if you guys will put your questions in the chat, we'll respond to them. So for the regulatory overview, so it's important from a QAPI perspective that you develop your internal quality measures, right? And then you implement them, and then you maintain them. Now, somewhere between implementation and maintenance, it should be a place for evaluate them. So when we're talking about maintenance, we're talking about really evaluating them and adjusting them to the needs of your organization. So you identify a problem, you develop your plan, you implement your plan, and then you continuously maintain it by monitoring and adjusting when necessary. All right, Nanette. So we want to focus on improved care and outcomes, actions, and documentation. So what the regulatory requirements tell us is, we're working to improve the palliative care outcomes, and as well as the actions that we take to improve them. And most importantly, on this slide is the documentation. So, it's kind of, if you're a nurse, and I'm sure Nanette will agree with me, but if she's a nurse and she goes out and she takes care of a whole bunch of patients and doesn't document anything, then we have a problem. So same thing for your QAPI program. If you want to improve your patient outcomes, you identified what issues you want to address, you take the action, but you never document any of your work, then it didn't happen. So very important. So go ahead, Nanette, as I fly through here. So your program scope, so what are we supposed to be doing? So we're supposed to, according to the regulations, measure, analyze, and track quality indicators, including adverse patient events and other things that affect the processes of care, your hospice services and operations. So what does that exactly mean? It means that you have to measure certain data elements, right? We know that there are several that CMS likes to see on our surveyors and accrediting bodies like to see. You have to be constantly analyzing what's going on in your organization. And I really think that assessing your processes here, so hospice services and operations, a lot of time we forget to include operations in our QAPI program, but that encompasses, employee files, right? Their records, your employee records. It can include your time to service, your referral sources. So think about that, and also think about the inclusion of your DME and your pharmacy and other organizations that you work with closely to ensure that you're meeting the scope intended by CMS. Okay, so one of the things that QAPI requires, the regulatory requirements, requires us to have an initial and comprehensive assessment of the patients. And I know that some of you may have a combined initial comprehensive assessment. Either way you slice and dice it, we still have to collect the same information and have the same form. So we want to have those data elements. So think about pain, dyspnea, nausea, vomiting, constipation, emotional distress, and spiritual needs. So we want to talk about, how quickly were we able to get that shortness of breath under control. We want our assessments to be consistent, right? So that takes a matter of training so that your team is documenting consistently on their initial and comprehensive assessment of the patient. All aspects of hospice care and palliation. So think about, volunteers, right? Think about having your bereavement coordinator involved early on so that they can provide that support. So when you're doing your assessment, what other services besides the nurse, social worker, and spiritual counselor and hospice aide might that patient need? So we also want to make sure that the initial and comprehensive assessment is systemic and that we're able to pull that information when we need it. And of course, your initial comprehensive assessment drives that initial plan of care and the comprehensive plan of care. It's the foundation. So we want to make sure that your assessment and your care plan fall in line, because then we're collecting the same data elements from the assessment and then we're monitoring them through the plan of care and the daily care of the patients. So coordination of care is super important. So how do you communicate internally about your hospice patients to find the very best interventions for them, just in general? I'm not even going to give an example. So how do you do that, right? Do you have internal communication notes? And what about external resources where you need to coordinate care with maybe, one comes to mind, the attending physician, right? We need to be coordinating that care. And then have a QAPI program to measure how all of that is going. So that's a quick overview, but you kind of get the idea. So let's talk about program data. So program data really should give you a really good idea of the things that you should be measuring, right? Patient services and activities and clinical services, that's really our starting point, right? Because from there, what do the clinical records look like? You know, are they organized? Are they put together? Do we have all the documentation? You're documenting what you're doing. More now than ever, infection control is top of mind for everyone, your pharmacy services and your DME. So while we're collecting this program data, I think just another reminder, when we're talking about pharmacy services and DME and other contract services, we really need to be bringing them into the fold while we're collecting data about the services that they provide. Patient rights can't be overstated. We've got administrative services, which I touched on briefly, and I really want to stop here on volunteers. So volunteers, it's not just about having them make getting them hired, in air quotes, you guys can't see me, but air quotes, right? So bringing them on board, getting them oriented, having them go out to see patients and complete that documentation, right? So you can get your 5%. You also want to make sure that when you're talking about volunteers, that they have a plan of care that they're following. Do they, you know, have they had their TB test? So lots of things go into each one of these data points. Your hospice aides, they need special attention, and adverse events. So we're talking about adverse events. Many people think, okay, well, that's a reportable. We need to call our state regulatory office and say that something bad happened to one of our patients. Well, I'd like to take a step back from that and really suggest that when we talk about adverse events, I like to include complaints in that, right? Because if we can get control of our complaints and really understand what's going on, then we can make the changes necessary to affect change so that those complaints go away. We don't have them anymore. So, and I know it's a lot to ask, but back on the day when I was in paper, I looked at every complaint form that was sent in and I followed it to its conclusion, and then we tracked them. So it really can have a large impact on your organization outside of being a required data element. So, all right. So let's talk really quick about our regulatory updates. So the HIS composite measure. So when we talk about, everybody gets excited, right? Oh my gosh, they're going to remove 7 HIS process measures. And I've heard that said a lot, but what we're going to do, what's going to happen is those process measures and those scores, the associated scores that you see on Care Compare, they're not going to be there anymore after May 22nd, May 2022. So those are going to go away, right? It doesn't change anything about the fact that you need to submit the data, the HIS data that that creates those process measures. It just means that it's not going to be out in detail for the public to see. All right. So next, we're going to talk about the annual payment update. So beginning in 2024, there's going to be a 4% reduction applied to the coordinating year for your failure to report that HQRP data. So think about the lag time here, and it's about 2 years behind. So you want to make sure that you are meeting that 90% threshold and getting your data submitted in a timely manner. So it also applies to CAHPS, so we want to make sure that we're getting that done as well. So hospice in the last days of life. So this has been discussed quite a bit, right? And it's part of the version 3 of the Hospice Item Set. So they're going to be, CMS is going to be discussing this and coming up with a way for the data to be reported in a different way. And what's important about this hospice in the last days of life, in the Federal Register, it very clearly sees that it should be, hospice professionals should be able to recognize a patient who might be in their last 3 days of life. So we need to start having those conversations with our team, making sure that we have that coordination amongst the IDG so that when we identify those patients, we increase our visits, our RN and social work visits. There's lots of talk about the adding the spiritual counselor and hospice aid, which I'm a proponent of. That's kind of in the pipeline, and I'm hoping to see it in my lifetime, but I'm not sure. And just remember that this data point, the hospice visits in the last days of life, will be publicly reported. So if you think about hospice and you think about people who are going to Care Compare, if they see that you're not having any visits in the last days of life, they're probably not going to choose your hospice. So not only is it maybe not in the best form to not have visits in the last days of life as a hospice organization, it's not good for the patient. It's probably not good for your team. It's not good for their loved ones. It's not going to be good for the consumers who see that maybe you're not seeing patients in the last days of life. Okay. All right. So CAHPS star ratings, it's coming. So 1 star is the worst and 5 stars are the best. So we're going to really focus on those top box scores. So for each of the 8 CAHPS hospice survey measures. So when you think about CAHPS, it's got all those different sections. There's 8 of them. And so the top box score is going to be a combination of the questions inside of each of the domains. So the way they're going to do it is they're going to think about how they adjust for case mix. And I'm not going to go into a lot of detail here. We're going to be looking at the mode of survey administration. So you may hear about mixed mode. So that's phone call and a letter. So different ways to do it. And so they're going to adjust their calculations based on that over time. So in a 2-phase approach. And so it's going to be adjusted for the size of your hospice, which is great news, right? But we're also going to look into the method or the mixed mode of how we get that information out to the clients. All righty, Ms. Nanette. So closing the health equity gap. So this is in process, right? And so what they're wanting to do is have improved data collection around the types of patients that you care for outside of their diagnosis, right? So we're really looking at the whole person. We want to look at disparity. So depending on where you are geographically and the community that you live in, you may have a very diverse community. So your hospice census, the patients that you care for, should reflect that. And the importance of this is really transparency. So we want to look and see what's really going on so that it will help inform public policy work. So this is an important initiative that's going on. You can find information on it on the CMS website, but I think any organization of interest should really kind of look into this and learn more about it and find out how they can participate. All right, Nanette. So the RFI, so Fast Healthcare Interoperability Resources, that's a lot to say, right? So when we're talking about this, we're talking about standards for exchanging of clinical information. So how do we have those interfaces, those APIs to facilitate the coordination of care and continuation of care of patients, of hospice patients? So how is all of that, how does all that happen, right? So what we really want to do, and the goal of it, is to improve the quality of care that the beneficiaries receive over their lifetime as a Medicare beneficiary. So think about their medical record would follow them throughout, or their clinical information would follow them throughout their time as a beneficiary. So there's many ways to get this done. So that one little single data transmission of data, it can be used in a multitude of ways. So what we want to do is streamline that data sharing over time. So that's what this is. And I have talked really fast. I'm going to turn it over to my friend, Nanette. Thanks, Nanette.
Thanks, Zondra. I appreciate all of that information. You're right. I feel like we've taken the whole just hospice quality reporting measure initiatives and everything and just tried to shove them into this 1 hour in service. But for the duration, like Zondra said earlier, we're going to get in and dig a little bit deeper into the Hospice Care Index and what that means for your organization. So what the Hospice Care Index? So the hospice final rule in fiscal year 2022 included this addition of a claims-based hospice care index for public reporting. So as Zondra mentioned earlier, it's really going to replace the reporting of the 7 hospice item set measures from a public reporting method. Obviously you still have to collect and submit your HIS data to CMS. The Hospice Care Index data is going to be the publicly reported measures in May of 2022, is what they currently have projected. And I am in agreement that CMS feels that this composite measure is going to better empower patients and family caregivers to make more informed healthcare decisions. You know, the problem with what we're measuring now is that you're looking at a time point at the beginning and you're looking at a time point at discharge. And so adding these measures will really help this component. The addition of that is, and we're going to talk about a little bit about HOPE as well. You know, they're trying to really figure out how do we look at the full gamut of services that we've provided and the care and quality included in that. So basically, the Hospice Care Index is a composite measure. It's made up of 10 indicators. It is obtained by the Medicare claims data. Now, that's a really great thing because you're not having another, like I said, we know HOPE is coming, but for this particular data set, they're really looking at and the things that you're already putting on your claim or that you have to report anyway, they're going to pull this information from. It looks at different aspects of those hospice services, and it's collected from admission to discharge or death. And it's really supposed to create an aggregate performance and look at trends and how you're looking compared relative to other hospices, which we know is important to determine where you're at, looking at your quality measures, your market share, and how you're functioning within that. So basically, hospice is awarded a point for meeting each criteria for each of the 10 indicators, and we're going to talk about those indicators. And the sum of those points is earned from meeting the criteria of each indicator that's lined out. So, and it's going to be a single score, and 10 is the highest hospice score. And obviously, that indicates it's a broad overview of the quality of provision of that hospice care. So this measure, the measure objectives, they're going to capture many aspects of hospice care. It's a set of claims-based quality measures. Again, that's a really great thing, not one more piece of data at this point in time to have to deal with. It's going to identify indicators based on caregiver and provider feedback, and then really align the index with the family and caregiver perspectives from CAHPS. So as Zondra mentioned earlier, you know, the goal is you've got this equation of what your hospice quality reporting program looks like. And so this is just one component of that. Okay, great. All right, so the different domains. They're looking at access, utilization, transfers, and nursing visits. May 2022 is that target date based on multiple indicators. And again, their overall score with a max being 10 is calculated as the total number of instances that the hospice met the threshold criteria. So what are these 10 criteria? I'm going to break it down a little bit further in addition to the slides that you have. So, you know, again, we're closed for time here. So if you need to at the end, if there's something that we weren't clear on, feel free to put a question in the chat, or that, you know, you can shoot us an email, let us know, and we can follow up with any questions you might have. So the problem is that the current hospice quality reporting measures, hospices are currently underutilizing that data. You know, it's calculated and looking at that at the beginning, at the end of the episode, and there's a lot of things that happen between admission and discharge, and it doesn't really direct the full range of those hospice services. So what are the measures? All right, so there's 10 indicators. Indicator number 1 is actually continuous home care, or GIP. It's looking at the provision of adequate services needed to manage patients' symptoms. And it's really going to identify and look at hospices that provide at least 1 day of hospice care under continuous home care or GIP, of course, based on those billing codes, whether it was 0652 or 0656, during the period examined. They're also going to look at excessive utilization of these services. You know, that can be really costly to the hospice and really may cause those inpatient CAP overages. On the other hand, underutilization is going to indicate that the hospice is not providing the care needed by the patient. So what they do is they take the total number of those continuous home care or GIP service days provided divided by the total number of service days provided at any level of care. If you score greater than 0, then you get 1 point, which means that the hospice provided at least 1 continuous home care or GIP service within that reporting period. So one of the ways to utilize or to provide additional help for this measure would be to educate your staff, obviously, on those levels of care, and as a part of what you're reviewing, definitely those clinical chart reviews to indicate, you know, eligibility, appropriateness for those levels of care. And again, with your QAPI program, to ensure the documentation and care that was appropriate for that level. So the second indicator is gaps in skilled nursing visits. So they really are looking at measuring the receipt of nursing visits, and they're looking at RN and LVN as outlined in the plan of care. And they're going to look at hospices who fall below the 90th percentile for patients with lengths of stay of at least 30 consecutive days, and that have at least 1 gap in 8 or more days without a nursing visit. And again, they're going to look at that based on all the levels of care: routine home care, continuous, inpatient, or GIP. And the calculation is made by the total number of lections divided by the total number of lections where the patient had at least 1 gap. And so it's going to exclude any length of stays that are less than 30 days, so that they'll get some actual real data with that. And then 1 point is awarded if the gap in nursing visits greater than 7 days falls below that 90th percentile. So you know, it's important. We realize we see patients sometimes that don't feel like that they need certain levels of care, but definitely that's not true, and we have to look at that. Let's see. Okay, so looking at, we've talked a little bit about frequency of nursing visits. They're also going to look at nursing minutes per visit for routine home care, and they're also going to look at visits on the weekend and visits near the time of death. Obviously, Zonder covered the hospice visits in the last day of life, and as she mentioned, this is going to become a public reporting issue. And then they're going to look at all this data and give us a real per beneficiary spending analysis of this. Okay, so let's talk about indicator 3, which is early live discharges. So what they're going to look at is it's going to measure the number of live discharges within the reporting period. If you have a high rate of discharge, then it may indicate that you're not compliant with eligibility criteria, or you have poor advanced care planning and you're not doing a good job of preventing hospitalizations or problems in your discharge process. Now, hospice, CMS does know that there is to be expected of some certain live discharges as patients choose to revoke or become ineligible. We've all seen that happen when you manage those hospice patients and you don't anticipate certainly that they will live for further days, much less at some point be discharged. But particularly with very poorly managed chronic patients, when we come in and we ensure compliance with medications and symptoms are managed, we end up providing a greater quality of life, and they end up having more time, which is a great thing, and you end up discharging that patient. And so the calculation, they're going to use the total number of live discharges in the first 7 days divided by the total number of live discharged and award 1 point if the hospice percentage of live discharges on or before the 7th day falls below the 90th percentile among hospice nationally. Okay, now what about late live discharges? Well, they're going to look at those live discharges occurring 180 or more after hospice enrollment. So the high rate of discharges after 6 months may indicate that the hospice is discharging patients and avoiding aggregate CAP overages according to the OIG. So definitely something to look at when you're thinking about your data. Okay, let's talk about those burdensome transfers. So one of the things to look at, indicator number 5, is a burdensome transfer, and they've actually got these listed. It's indicator 5 and 6. You've got burdensome transition type 1 and burdensome transitions type 2. So type 1 is live discharges from hospice followed by hospitalization and subsequent readmission. So they're going to look at the number of live discharges who have a hospital admission within 2 days of the discharge, and then a readmission to hospice within 2 days of that discharge. It's definite. A situation like this is really it reflects poor poor care or care processes that haven't been adequately implemented. Certainly fragmented care. And something you have to be very careful about as an agency. What about type 2 burdensome transitions? Well, this live discharge from hospice following a hospitalization, and then the patient ends up dying in the hospital. So it really looks at those live discharges who then we discharged them. They went to the hospice. They went to the hospital within 2 days of discharge of the patient, and they ended up dying during that hospitalization. Certainly, was this an inappropriate discharge of patients who were not stabilized prior to discharging? And so, we've all had tricky patients and patients that are difficult, you get family members involved who don't understand hospice and revoke care, and various things happen. So you cannot understate the importance of that initial comprehensive assessment, those initial visits, in thoroughly informing and educating patients and families on what hospice can and cannot do. And as Zandra said, making sure that we're using those CAHPS surveys, those CAHPS measures, to tell them what they're doing, take credit for what, we're going to talk about. Today we're going to talk about, and I'm going to provide some education for you on how to care for your loved one. And so how we frame those ideas makes a huge difference. So one of the other things they're looking at, indicator 7, let me move my slide here. Oh, okay. So indicator 7 is talking about per beneficiary Medicare spending. And so they're going to really look at whether a hospice is below 90th percentile in terms of average Medicare payments per beneficiary. And then calculations for hospice payments per number of unique beneficiary number for reporting year. You know, the problem is that MedPAC has revealed that nearly half of Medicare hospice expenses are for patients who have spent at least 6 months or more on hospice. And so are they not discharging patients appropriately or selectively enrolling patients with non-cancer diagnosis and longer predicted lengths of stay? And of course, the OIG is also concerned about inappropriate billing of GIP care. So something you really have to look at and think about when looking at that. Okay, so skilled nursing care, indicator 8 is skilled nursing care minutes per routine home care day. And so measuring the amount of time spent by an RN and LVN for routine home care days when billing that revenue code 055X and counting each reported unit and multiplying by 15. So each unit is 15 minutes of time spent. And so they're going to really look at what does that look like, and the total skilled nursing minutes provided by a hospice on all routine care services divided by the total number of routine care days. And so definitely, you know, when you have staff that is, when you're understaffed or you have a certain influx of patients, you're going to have certain things that are going to affect your time and your quality and your ability to care for patients. But it's not acceptable to provide poor care or not enough time to provide what the patient and family or facility, if you're overseeing the care, to provide the education to those ones caring for that patient. Indicator 9 measures the number of minutes of care. It's skilled nurse minutes on weekends. So they're going to particularly look at what nursing care is being provided on weekends. Hospice COPs require nursing services to be routinely available 24 hours a day, 7 days a week. And, you know, CMS says, yes, we realize that most patients may have more care available on weekends. They're going to look at patterns of variation and some of those providers that could signal, you know, problems with provider availability or access for care. And so actually, honestly, it's going to be really interesting to see how all of this lines out. And then the last measure, indicator 10, is that visit near death, looking at RN, LVN, or social work services performed in the last 3 days of life. And I'm with Zandra that they need to be looking at the other measures as well, looking at home care aid and spiritual support services that are in the home as well. Obviously, we know that the last few days of death are a time of increased symptom burden. It's physical, emotional, and certainly requires those skilled hospice visits. And they've also stated that they know that there's going to be GIP visits that are going to include skilled nursing visits, and those may not necessarily appear on the claim. So something, you know, to look at that and how that's going to be viewed as well. So, okay, well, let's move on a little bit. I hope that was informative, a little more detail about the Hospice Care Index and how you can begin to really get ready for that. So obviously these confidential quality measures, the report's going to be revised to include these claims-based measure scores. It's going to include the results of the individual indicators and provide details on those indicators, of course, with the overall score max being 10. And then it's going to be available at that provider data website. So what future quality measures are we looking at? You know, you've got currently CMS collects data at admission and discharge, and that data is used to calculate measures in the HQRP, future outcomes and other quality measures arriving from HOPE in addition to those measures. So, you know, you've got administrative data now with HOPE, with CAHPS, and that's going to become your hospice quality reporting program. Looks a little bit different than what Zandra mentioned earlier from right now. So the HOPE assessment measures concept, So what this is, and it's been actually in process, in development. I think currently, I believe in the spring, and Zonder, you can jump in and correct me on this if I'm wrong, but I think in the spring they were doing their beta testing and starting on that. And CMS has contracted ABT Associates and to look at these measures, and we don't know what those necessarily what those measures are. Some of the concepts that they've calculated or looking to look at are timely reduction of pain, reduction in pain severity, timely reduction of symptoms. And so they're going to look at those over multiple time points across the stay, and really looking at those outcomes. It's different to look at what was a process measure at the beginning and what was a process measure at the end. But really, what the goal is to look at how can we affect the outcomes, and how do we know that this hospice is providing quality of care. And so, to have those HOPE pain and symptom measures in the program as soon as possible, they're currently developing those measures for future use. So we don't have a timeline. We don't have everything, for sure to when that's going to be implemented. And of course, as everything with the pandemic has slowed down some of the process of that. But definitely they're looking at how to look at that and how to move forward. They're going to be data collection, as we know right now, when they implement this, is going to be at admission, at symptom reassessment, and at a level of care change, and at recertification. And I know those of you who are familiar with home care and you think about the OASIS data set, it's in some ways similar to that. I know hospice is a completely different animal and you cannot compare apples to oranges, but when you think about the requirements of that data set, it can kind of help you think through that process of what that expectation is. And currently, I said they're doing field testing for reliability and validity, and obviously they're going to implement a future quality tool when the testing is complete. And it's probably closed now, but I know there was a way for many organizations to go ahead and enter and be a part of that pilot project. So okay, so public reporting of quality data. The CAHPS hospice survey participation has been a requirement, and for the fiscal year and subsequent years. So we know this is a component of it, and I just wanted to bring a couple of things to mind. That CMS proposes public reporting to continue to be the most recent 8 quarters of data, and they are going to exclude Q1 and Q2 of the current year 2020. As far as volume-based exemptions for the CAHPS hospice survey data collection and reporting, they really didn't make any changes to that. Again, they're looking at how the pandemic affected that. Again, it's looking at that quality data, and it's interesting to me that the public's opinion on how you've done something is going to be something that is a part of public reporting. So we're looking at CAHPS, you're looking at that star rating, you've got your hospice visits in the last days of life, and then your hospice care index as well on that quality data and how to look at that. So, well, gosh, we finished 5 minutes early, and I feel like we have just given you a ton of information. So we do have time for a couple of questions before we finish up here, if anybody has anything. All right, well, I don't see Any questions in the chat? I know that it's been an extreme pleasure to be with you today. And thank you so much for allowing us to present this information to you. And I'll turn it back over to Zandra and to Axxess as our sponsor, and then to Hospice News if there's anything else we need to cover before we finish our presentation.
Thanks, Nanette. I feel like we peppered them with a lot of information really quickly.
Yes, we did.
We did. So like Nanette said, we are happy to answer any questions that you have. I know there aren't any in the chat right now, but we're here to support you. We want to help shore up your quality program. So feel free to reach out if you have any questions for us. And with that, I'm going to turn it over to Jim if he's there. If not, we will conclude our webinar and hope everybody has a really super day.
Hi, Zandra and Nanette. I am indeed here, and I'd like to thank you for your insights and for sharing your expertise with us today. It was a great discussion, so thank you for being here. And I'd also like to thank, of course, everyone who tuned in to listen today. Thanks very much, and please take care.
Thank you for joining our on-demand training today. Axxess is the only home healthcare technology company approved by the American Nurses Credentialing Center to offer continuing education credits and the most recommended home health software on software advice. You can watch more on-demand training videos through our industry-leading help center or at axxess.com, where you'll find tutorials, blogs, white papers, and answers to frequently asked questions. Axxess, empowering care anytime, anywhere.